Yeah, good morning all. I'm Dr. Abhilash, KPP, Professor and Head of Emergency Department at CFC Vellore. It's great to be on this forum, and today I'll be talking about general management and initial approach to the management of a poison patient. And you can ask the question, what is a poison? Uh, any compound, any drug, any chemical can be called a poison depending on the dose that it is taken. If it's taken in a therapeutic dose, it may be beneficial, but anything that goes beyond the therapeutic dose could be toxic. And that is what a toxin is. So, there are many drugs, insecticides, herbicides, plant toxins, chemical weapons, radioactive elements. These are not so common in India, the last two, but they're all toxins that need to be managed in the emergency department on a regular basis for us. So, initial management, the basic concept is that if the patient life is in danger, what we learn as part of our ACLS and cardiac life support, airway, breathing, circulation, and these are the cornerstone in the management of any poisoning patient. You can add one extra thing called dextrose or disability in a poisoning patient, and that would be the initial management of all poisoning patients, irrespective of the toxin they might have consumed. So, airway, the basic thing to do as emergency physicians is to clear the airway of any obstruction, vomiters. If necessary, and the patient is sensorium is low, you can consider oral airway, nasotracheal airway, or even endotracheal intubation in order to protect the patient airway. For many patients, just moving the flaccid tongue out of the airway, and by doing the airway maneuvers is all that is required to stabilize the airway. Next comes breathing. Some patients may require mechanical ventilation. Some drugs like heroin or opioids may require that depressed respiratory drive. They could require respiratory supports in terms of non-invasive ventilation. And sometimes, if the dose is very high and toxic range, patients may require ventilatory assistance, that is invasive ventilation. Next thing that we learn is circulation. All patients with any poisoning, as with other emergencies, require continuous monitoring of pulse, blood pressure, respiratory rate, urine output, um, and all that. And some drugs like beta blockers, for example, or calcium channel blockers may impair myocardial contractility, and some may cause arrhythmias. So this requires careful monitoring, and some of these compounds may result in fluid overload state. So circulation has to be assessed and stabilized, either hypotension or the other way, hypertension may have to be controlled, and circulation has to be stabilized. After this, these three ABC stabilization comes the essential assessment of history and physical examination. A careful history has to be taken from all the patients because this is the most valuable tool. Sometimes some children or psychotic adults or patients with depressed consciousness may not give a reliable history. So even the relatives may not, the person standing next to the patient may not give a proper history of the exact compound consumed or the time of consumption of the compound. So you must try to catch the most reliable relative or the patient's attendant and get an accurate history. I always tell my registrars to call up or ask the relatives who may be somewhere near the site of the incident to search the living quarters and find the empty containers or pills that they may have consumed and WhatsApp the images. If they have consumed a plant poison, I tell my registrars to make sure that the relative somewhere over there takes a picture of whatever they have consumed and send, so that we may get a better picture of what they have actually consumed. And then the appropriate interventions can be taken. But without a proper history and assessment of exactly what compound they took, what dose they took, it's very difficult to manage any patient with a poisoning. And sometimes pharmacy and medical records of a patient on regular follow-up may be useful to give good information on what they might have consumed. If regular medications of sometimes even the patient or even the relatives of the patient, through which the patient can access the medications at home. Toxicodrome is a group of signs and symptoms that may be associated with overdose. The different types of toxicodrome, like opioid toxicodrome or organophosphorus poisoning toxicodrome, that everybody should be aware of. to examine the patient and identify the toxidrome and take appropriate steps. I won't be going into details of it because, as far as I know, this topic is covered by another speaker in the same series. So let's come to the general management of any poisoning patient. These are the 4 steps that everybody has to be aware of and implement in any managing any patient with any poisoning. One is provision of supportive care, which is common to all poisonings and all emergencies in general. Second is preventing absorption of the poison that may have been consumed. Third is elimination of also enhancement of elimination of the poison. And fourth is administration of antidotes. So I repeat, provide supportive care, prevent absorption of the poison, enhance elimination of the poison, and administer antidotes. So these are the 4 main steps that have to be taken in the general management of any poisoning. First is provision of supportive care. This includes vital signs monitoring the mental status, pupil size, especially look for any pinpoint pupils in opioid poisoning or any datura or any plant poisoning. Cardiac monitoring, ECG, and you protect the airway, assess airway, breathing, circulation. All these are part of supportive care of any poisoning or in general emergencies. Second is prevention of absorption of the poison. There are many ways of preventing absorption of poison. Depending on how the poison has been consumed, could be dermal absorption, could be ocular absorption, inhalational injuries, or could be ingestion of any compound. If a patient has dermal exposure, let's say an organophosphorus poisoning or a pyrethroid being sprayed and contact with the skin, or any chemical exposure, the patient has to be undressed and washed thoroughly by using lots of lukewarm water. If not, any water available is enough. But the dermal exposure has to be cleared for at least 30 minutes. A continuous long cleaning is what is needed. That is when you need the decontamination rooms. I don't know how many hospitals have decontamination rooms, but one room with a hand spray is what is needed. If that's available, patient can be sprayed with water, and all the poison on the skin can be washed off for a long enough duration of time. And that's dermal decontamination. Some poisons, toxins may require soap and water washings, like organophosphorus pesticide, which are quite common occupational exposure. So they may require a longer wash with soap and water if possible. And make sure that the person doing the decontamination of the skin wears protective clothing so that he or she may not get exposed to the toxin. If the patient gets exposed to the toxin intentionally or intentionally through the eyes, then the eye wash, ocular irrigation is what is recommended. Patient has to be laid supine, and the eyes have to be washed with a large volume of water or even normal saline for at least 10 to 15 minutes. So if you look back at any poison that you might have managed with ocular toxicity, did you really wash the eye for 10 to 15 minutes? Very unlikely. Most people stop with 3 to 5 minutes of irrigation. But what is recommended is a long enough duration of 10 to 15 minutes of ocular irrigation with normal saline or water. So, and ask the patient to keep blinking the eye so that it gets washed out sooner. If in some compounds like acid or corrosives, it gets exposed, if they fall into the eye, then you may have to check the pH of the eye. If that's very low or abnormal or very high, depending on the compound, acid or alkali, you may have to continue irrigation till the pH normalizes. But if you have a pH meter, it's good to check. If not, at least 10 to 15 minutes of washing is mandatory for any ocular exposure of any toxin. And if a patient continues to have symptoms, you will have to have ophthal examination, referral to ophthalmology at the earliest. If a patient gets exposed to an inhalational toxin, then move the patient to a fresh air environment as soon as possible, and make sure that the respondent, that is you, are protected from this airborne toxin. And depending on the toxin, we may have to take further measures, which I'll come to later. If a patient ingests a toxin like organophosphorus or any other chemical, any Dettol or any corrosive, then there are ways to minimize the absorption. That is by inducing vomiting, by gastric lavage, use of adsorbents, cathartics, whole bowel irrigation. These are all different methods of minimizing exposure, minimizing the amount of poison that is um, absorbed into the systemic circulation. Induced vomiting, should you induce vomiting to a patient? This Epicac solution was recommended for many years, but nowadays this is not even available. So if the patient can self-induce vomiting and can vomit, it may be okay, but then it's not really recommended to induce vomiting because that can cause a lot of problems if the retching becomes too much. So it was shown to have a good amount of vomit being induced, this Epicac solution and other saline solutions, but it's not really recommended nowadays. Gastric lavage, again, this is a very controversial issue. Some recommend and many people don't recommend. But what is known is that you can use a orogastric tube, or nowadays it's only nasogastric tube that is used, because orogastric tube is not available. It's a large lumen tube. It's not available nowadays. So you can use a regular nasogastric tube that you use for NG insertion and use that and irrigate the stomach contents, push in some normal saline, and using a dependent position, remove the stomach contents. So this can reduce the amount of toxin in the stomach if the patient has ingested the toxin. But remember that it is not safe if the patient is unconscious unless patient is intubated, because there's a risk of aspiration. So by trying to do a gastric lavage, you could cause a lot more harm. And also, patient with caustic ingestion, like corrosive poisoning, do not attempt a gastric lavage, no matter what the duration of presentation may be, because it could cause more harm. So there is, as I said in the beginning, it's controversial. Most people don't advocate the use of lavage, but if the patient presents is in less than an hour of ingestion, you could consider it, but make sure the patient is conscious or the airway is protected. In the sense the patient is already intubated and airway is very clearly protected, then you can do it. But avoid lavage if the patient presents with more than 2 hours of ingestion. It causes a lot more harm than benefit. As I said, the drug removal ranges between 35 to 50%, but definitely indicate if the ingestion is less than 1 hour since to the time of presentation. More than 1 hour, try avoiding lavage as much as possible. Adsorbents are substances that can attract and hold the toxin, and after which it can be removed from the body. Activated charcoal is one thing that is commonly used. It traps the drug or toxin to its large surface area and prevents absorption from the GI tract. So that's something that can be used. It's a non-specific binder. Again, the same as gastric lavage. Use it if the patient presents within 1 hour of consumption of the toxin. Beyond 1 hour, avoid lavage and charcoal, because this could cause aspiration and cause more harm if given. Indications for charcoal: you need to know that every drug is not, or every toxin is not absorbed to the charcoal. It should be given, should not be given if esophageal or gastric perforation is suspected or emergent endoscopy is required. Like, for example, corrosive poisoning, you need emergency endoscopy. So avoid charcoal in such situations. As I've been saying, aspiration or impaction is very possible. So use it when absolutely necessary. If not, if you can avoid this. So these are the drugs you need to remember. I want you to look at this slide very carefully and note down the compounds that adsorb to activated charcoal. The ones on the left side: acetaminophen, amphetamines, aspirin, barbiturates, benzodiazepines, cocaine, opioids, phenytoin, theophylline. These are the drugs that are adsorbed by activated charcoal, and you could use this for preventing the absorption. But the drugs on the right side, like acids, alkalis, alcohol, iron, lithium, or some metals, these are not adsorbed by charcoal. If patient presents with any of these on the right side, do not try activated charcoal. It's of no use at all, and it could cause more harm. So this is one slide that you need to know and remember when to use charcoal and when to avoid using activated charcoal. Another option is whole ball irrigation. The goal is to induce to promote excretion of the toxin in the GI tract at the earliest. This is like giving oral contrast for a CT scan. You load this balanced electrolyte solution in a bottle and make the patient drink a large volume so that the toxin gets eliminated from the GI tract at the earliest. But again, this is not used for every single toxin that may have been ingested. It's useful for heavy metals, iron, lithium, or some extended release preparations that could continuously keep getting absorbed in the GI tract. You could use whole ball irrigation. But you must be very careful that if a patient has signs of perforation or absent bowel sounds, don't use this because it could cause more harms. It could cause bloating, cramping, and perforation. So avoid whole ball irrigation if patient has absent bowel sounds or features of obstruction. You don't want to give an additional compound if patient already has features of obstruction. So avoid this if you can, but consider this in cases of heavy metal, iron, lithium overdose or extended release preparation medications. So third important step in general measures of any poisoning patient is enhancement of elimination of the poison. This could be the absorption rate, body distribution, metabolism, elimination. All this must be considered when choosing the method to eliminate the drug or toxin. So there are different methods. There used to be a lot more options earlier, but not always used. Nowadays, multiple dose activated charcoal, chelation, hemodialysis, and hyperoxic oxygen therapy are the ones that are commonly used to enhance elimination of a poison from the body. Multi-dose activated charcoal, again, I already spoke to you earlier about charcoal being used as an adsorbent. Some conditions, some drugs which are extended release preparation like theophylline, phenobarbital, carbamazepine, valproic acid. These drugs, if the patient has consumed any of these drugs, you could consider multiple doses charcoal, which is basically administering charcoal multiple times in the first 24 hours to absorb the drugs in the GI tract. You can repeat the doses every 2 to 6 hours, depending on the amount of drugs or the toxin consumed by the patient. The second mode of elimination of the drug is chelation. This option can be considered in poisoning from certain drugs like mercury, lead, iron, arsenic. These are heavy metal compounds. If patient has consumed any of these, either as occupational exposure or deliberate self-harm, you could consider chelation by using certain drugs like diamicroprol, EDTA, desferrioxamine in case of iron overdose. These are drugs that are used for chelation of these heavy metals. So in specific conditions, you could use chelation as an option. Hemodialysis is another option that can be used for certain drugs that are water soluble. So to consider hemodialysis, the drug should be dialysable, should have low molecular weight, low protein binding, and should be water soluble. So if these criteria are fulfilled, which would be drugs like salicylates, methanol, lithium, theophylline, some mushroom toxins, these are easily dialysable. If a patient has consumed any of these drugs, you could consider hemodialysis as an option to eliminate the drug from the body. Hyperbaric oxygen is another option that is specifically used for carbon monoxide poisoning, and sometimes in high altitude illness where a patient can be kept under in an environment of high pressure. But you can imagine that is a very cumbersome procedure. It's not available in most hospitals. This kind of environment where you have a metal box or a container where a patient can be kept inside to increase the pressure. So these are mostly outdated nowadays, used in very specific situations of high altitude illness. When a patient is at a very high altitude, has to be brought down. In those situations, there are equipment available where the adventurers take this equipment up the mountains, and in case of emergency, they can be used. But in most hospitals, this option is not possible. So in case of carbon monoxide poisoning, what is done is giving high concentration oxygen, but hyperbaric oxygen can be used in certain specific situations if the option is available in that hospital, but more of anecdotal use than regular use nowadays. These have complications like otalgia, sinus pain, tympanic membrane rupture, tension pneumothorax. All these are complications of putting a patient in a high pressure environment, that is hyperbaric oxygen therapy. So because of this, this mode of elimination of the toxin is not in favor nowadays. So the last general measure that can be used in any poisoning pain, probably one of the most useful measures, is administration of antidotes. But remember that most poisons don't have an antidote. In fact, very few antidotes are available for compound. The number of compounds available for a patient to take for deliberate self harm is so much more than the available antidotes that very few have antidotes. So this is a table that you need to look at carefully and memorize and be aware of the specific antidote and the dose that you have to administer. For acetaminophen, N-acetylcysteine, intravenous is the antidote that is available now. When I was a postgraduate, we used to give oral N-acetylcysteine, but that is out of vogue. It's very cumbersome procedure to give a patient oral N-acetylcysteine. So nowadays, it's an IV N-acetylcysteine is the standard antidote for acetaminophen poisoning. Benzodiazepines, flumazenil is the antidote. Carbamates, organophosphorus poisoning, atropine is the antidote. We don't use pyridoxine at all now for even organophosphorus poisoning. Atropine is all that is needed. For digitalis glycosides, digoxin specific Fab antibodies is the antidote, but that's not available in India. Abroad, in some countries, available. India, this is not available. It's very expensive. So even though we teach PGs about this, it's not available in India. Ethylene glycol or methanol, ethanol is antidote. Opioids, that's one very important thing. More prevalent in the West, where many people take opioids and come, and for which naloxone is even recommended as the one of the drugs to be considered during ACLS. India is not so common. At least in South India, where I work, it's not so common. Some places in the north, I know that opioid abuse is very common. There, you could consider naloxone as antidote early in the management of patients. Tricyclic antidepressants, sodium bicarbonate is can be considered. So to summarize, the general management of any poison patient, the first and foremost is stabilize the airway breathing circulation, as we do for all emergencies, be it poisoning or trauma or medical surgical emergencies. ABC is the first thing for in the management of any patient. Take a good history to identify the toxin. Dig deep, catch the relative, find the person who may be at home and make them take pictures of the, I would call crime scene or the incident scene, and send you pictures, or you can look at the what exactly patient has consumed, and you can search and find the exact toxin, so that you may be able to administer the appropriate decontamination or elimination or antidote if needed. Consider decontamination, could be dermal, could be ocular, could be inhalational, could be ingestion, whatever they may have, mode of consumption, you decontaminate appropriately. Prevent absorption as much as you can, like gastric lavage and charcoal, but remember, give it only with the patient present within 1 hour of consumption of the toxin. Beyond 1 hour, be very cautious in giving lavage or charcoal, because it could cause more harm if the patient, especially the patient is altered or sensorium is low. Enhanced elimination, consider options like whole bowel irrigation, hemodialysis, or multi-dose activated charcoal, or things like EDTA and other cathartics that you can give to enhance elimination. The last general measure is, if an antidote is available to any specific compound that the patient may have taken, immediately administer antidote so that you could reverse the toxicity. So if possible, administer antidote. Otherwise, stabilize ABC, identify the toxin, decontamination measures, prevent absorption, eliminate and enhance elimination, and administer antidotes. So this is the summary of management of any patient with any poisoning. So with this and my presentation, happy to take any questions that you may have and answer them all.